Hello, I'm Bobby Jean Schweitzer, and I will be presenting Endocrine and Metabolic Systems Part 2. This lecture module will consist of a discussion of thyroid disorders and pheochromocytomas. Let's start with the thyroid disorders. And start with a question. A 21-year-old male presents to your ambulatory surgery center for a knee arthroscopy. He appears very anxious and has a tremor. Upon further questioning, he endorses a 20-pound unintended weight loss, insomnia, and palpitations. You suspect hyperthyroidism. Treatment of thyroid storm would include all of the following except A. Propylthiouracil, B. Beta blockers, C. IV fluids, D. Radioactive iodine administration, or E. Acetaminophen. And the answer is radioactive iodine. So answer D is correct because if radioactive iodine is given before the thyroid is suppressed, it can be used as a substrate for thyroid hormone, and it can actually worsen hyperthyroidism and thyroid storm. Answer A is incorrect because propylthiouracil suppresses thyroid production of T3 and T4 and decreases conversion of T4 to the active form of T3. Answer B is incorrect because beta blockers slow the heart rate and lower the blood pressure, both of which are elevated in hyperthyroidism. Answer C is incorrect because volume depletion is common in thyroid storm. Answer E is incorrect because acetaminophen reduces hyperthermia, which occurs with thyroid storm. So let's talk about the hypothalamus pituitary thyroid axis. Some review of basic science here. Thyroid releasing hormone, which is also a TRH, occurs from the hypothalamus, which then stimulates thyroid stimulating hormone, or TSH, from the pituitary gland, which stimulates the thyroid to release T3 and T4. So the hypothalamus controls the pituitary, which controls the thyroid. There's a negative feedback loop in this, where T3 and T4 suppress further TSH from the pituitary, and T4, T3, and TSH all suppress TRH, or thyroid releasing hormone, from the hypothalamus. Remember, T4 is converted to the more active T3 in peripheral tissues, and T4 and T3 are metabolized and excreted by the liver. So the pictorial is a nice demonstration of, again, the downward influence from the hypothalamus through the pituitary to the thyroid, and then the backward feedback loop from the thyroid gland both to the pituitary and the hypothalamus. So what is hyperparathyroidism? Well, the etiology varies. The most common is Graves' disease, but it also occurs from thyroid adenomas, subacute thyroiditis or inflammation of the thyroid, a toxic multinodular goiter, or pituitary tumors that secrete thyroid stimulating hormone, which then stimulate the thyroid, and iatrogenic excess of thyroid replacements. Hyperthyroidism has the classic findings of a goiter often, and ophthalmopathy with bulging eyes. Laboratory findings consist of increased thyroxine, which is T4, and triiodothyronine, which is T3. And laboratory findings will also consist of a decreased thyroid stimulating hormone, or TSH level. Features of hyperthyroidism include weight loss, heat intolerance, palpitations, chest pain, tremors, diarrhea, anxiety, muscle weakness, hyperactive reflexes, a goiter, dermatopathy, or skin changes, clubbing, and ophthalmopathy, or bulging eyes. And those are demonstrated here in the pictures. And what are the physiologic effects of hyperthyroidism? Well, primarily, it can affect almost every organ throughout your body because it drives metabolic rate. For the cardiovascular system, patients can and frequently are hypertensive and tachycardic. They will often have arrhythmias, especially atrial fibrillation. In fact, the cause of atrial fibrillation in elderly patients are so commonly associated with hyperthyroidism that any patient presenting an atrial fibrillation should have a thyroid levels checked. Increased heart rate or tachycardia, increased contractility, and increased cardiac output. One can even see a high output cardiac failure or heart failure, especially in elderly patients. In the pulmonary system, because of the increase in metabolic activity, it increases O2 consumption, increases CO2 or carbon dioxide production. One sees an increased respiratory rate, increased tidal volume, and overall increase in minute ventilation. Thyroid storm, thank goodness, is a relatively rare complication of hyperthyroidism. This is, though, can be a life-threatening condition. Often the etiology on top of underlying hyperthyroidism is infection, stress, trauma, diabetic ketoacidosis, labor, IV contrast, or thyroid surgery. This is an exaggeration of the usual symptoms of hyperthyroidism, sort of hyperthyroidism on speed. One can see an altered mentation. In fact, some people suggest that one must have an altered mentation or one cannot diagnose thyroid storm. Anxiety, coma, and delirium. Heart failure, tachycardia, typically with heart rates as high as even 140 and above. Hypotension or low blood pressures, hepatic failure, nausea, vomiting, hyperpyrexia or elevated temperatures, and even death. The laboratory values consist of elevated T3 and T4 and a low TSH. The only exception to the low TSH is in patients who have pituitary tumors that are thyroid producing, that are producing TSH, which is driving the thyroid. Then one would see elevated T3, T4, and elevated TSH. The patients typically have hemoconcentration and leukocytosis. Abnormal liver function tests are not uncommon. They have hyperglycemia and elevated calcium levels. So the treatment is intensive care management in the ICU with monitoring, cooling the patient, lowering their temperature, both with low ice packs or acetaminophen and fluids. Beta blockers can control the increased adrenergic tone, lower blood pressure and heart rates. Propylthiouracil or PTU or methimazole blocks hormone synthesis. It also reduces T4 to T3 conversion. Potassium iodide, which is supersaturated potassium iodide or SSKI or Lugol solution or other names for it, block hormone release from the thyroid. You need to delay this for at least 1 hour after PTU or methimazole to avoid the potassium iodide being used as a substrate to actually cause an increased production of thyroid hormone. Glucocorticoids can reduce T4 to T3 conversion and promote vasomotor stability. Cholestyramine can decrease the intrahepatic recycling of thyroid hormones in patients who have taken an overdose of thyroid hormone and have iatrogenic cause. So what about anesthesia implications for thyroid surgery in patients who have thyroid storm? Well, first you want to try to delay anything except completely emergency surgery. These patients typically have very low blood pressures with high sympathetic tones. They can behave very much like patients with pheochromocytomas. You should provide sufficient anxiolysis and anesthesia, particularly before painful procedures or endotracheal intubation. It's important to monitor the recurrent laryngeal nerve to avoid injury. Therefore, one needs to avoid neuromuscular blockade at the time of monitoring. Video laryngoscopy to place the monitoring endotracheal tube is usually the standard of care now, so that it can be clear that you get the electrodes right at the vocal cord level, and even the surgeon can participate in adequate placement of the endotracheal tube. There's about a 5 to 8% incidence of difficult intubations due to goiters or airway compression or deviation. These are usually goiters that from malignant etiologies or substernal goiters as opposed to simply benign goiters. A substernal goiter can have similar effects as an anterior mediastinal mass, depending on how far down it goes. So you use the same kinds of principles that apply to taking care of a patient with an anterior mediastinal mass, and this may include maintaining spontaneous ventilation during intubation, considering a wake fiber optic intubation or an inhalational induction, and the situation with possible hemodynamic compromise, particularly when the patient lies supine. What are the post-operative complications from thyroid surgery? Well, probably one of the most feared is airway obstruction from hematomas, but also airway obstruction from bilateral recurrent laryngeal nerve injury, which should be at a lower risk in current modern day monitoring of the recurrent laryngeal nerve during the surgery. But if you have bilateral recurrent laryngeal nerve palsies or injury, then you have unopposed action of the cricothyroid muscles. The cricothyroid muscles are actually tensors of the vocal cords via the external branch of the superior laryngeal nerve. So that means that the vocal cords will be opposed in midline and tensed, causing airway obstruction. More delayed postoperative complications are hypoparathyroidism, in case the parathyroids were inadvertently removed or damaged during the thyroid surgery. This can result in hypocalcemia 24 to 96 hours postoperatively, resulting in tetany and laryngeal stridor progressing to actual spasm. Hypomagnesemia can also precipitate hypocalcemia. So what are the etiologies of the opposite of hypothyroidism or underactive thyroid function? The more common is primary, which is the most common is autoimmune. Also radiation therapy. In fact, any patient who has had head and neck radiation should be followed on a regular basis with routine thyroid hormone levels. And idiopathic causes. Secondary causes are pituitary or hypothalamic insufficiency, because as we noted, the thalamus drives the pituitary, which drives the hormone, the thyroid. Complications of hypothyroidism consist of generalized reduction in metabolic activity, sort of the opposite extreme of hyperthyroidism. These patients often complain of being lethargic, they have cold intolerance, they have weight gain, they are predisposed to bradycardia and decreased cardiac output, rather than tachycardia and increased cardiac output as seen with hyperthyroidism. They have a decreased ventilatory response to hypoxia and hypercarbia, especially when sedated. They can be anemic and have coagulopathies. They also have impaired free water clearance and may have hyponatremia. So the treatment of hypothyroidism is obviously to replace the thyroid hormone. The most common replacement is levothyroxine in doses of about 200 to 300 micrograms, either as an IV bolus or 100 micrograms IV every 24 hours. One should use caution in elderly patients or those at risk for ischemic heart disease and perhaps go more slowly. Steroids may be beneficial and useful. Many patients have coexisting adrenal insufficiency, in fact about 5 to 10%. So if you are going to use hydrocortisone, depends on how significantly hypothyroid the patient is or other comorbidities, but 25 to 100 milligrams IV Q8 hours should be sufficient. Try to avoid opioids and sedatives due to the increased sensitivity these patients have and the decreased respiratory drives that they have. Preoperative normal thyroid state is optimal before proceeding with any kind of surgeries other than truly emergency surgery. Remember that the thyroid function tests lag behind the clinical state, so it's unclear when it's safe to proceed, but generally within likely a few days to a couple of weeks of starting hormone therapy, especially if the patient's symptoms have resolved or are resolving, it's likely safe to proceed before normalization of thyroid hormones. Just a reminder, only emergency surgery is appropriate in patients with severe hypothyroidism or myxedema coma. So anesthetic considerations include, during the course of management intraoperatively, is judicious or careful use of anesthetics and sedatives. These patients, again, have increased sensitivity to sedatives, hypnotics, opioids, all anesthetic agents. They have enhanced cardiac depressant effects because of the decreased metabolic activity. They have a decreased respiratory drive. It's important to maintain normothermia because these patients have difficulty modulating their body temperatures. You should avoid or treat hyponatremia. You should maintain normal glycemia. Hypothyroid patients are prone to hypoglycemia, which can be dangerous, and maintenance of intravascular volumes. So let's do a question. You are preparing to wake up and extubate your patient after a total thyroidectomy. What symptom or complication should you be on the lookout for? A. Stridor suggests bilateral recurrent laryngeal nerve damage. B. Dysphonia occurs with bilateral recurrent laryngeal nerve damage. C. Unilateral recurrent laryngeal nerve damage results in aphonia. D. Unilateral recurrent laryngeal nerve injury is more serious than bilateral recurrent laryngeal nerve injury. Or E. None of the above. And the correct answer is stridor suggests bilateral recurrent laryngeal nerve damage. Sorry about that double damage there. Answer A is correct because if both recurrent laryngeal nerves are injured, then the vocal cords will be adducted in the midline, causing stridor and airway obstruction. Answer B is incorrect because if both recurrent laryngeal nerves are injured, the patient will be aphonic, not dysphonic. Aphonic means no voice. Dysphonic means a hoarse voice. Answer C is incorrect because as long as one vocal cord or recurrent laryngeal nerve is working, the patient will only have dysphonia or a hoarse voice, not absence of voice or aphonia. Answer D is incorrect because if both recurrent laryngeal nerves are dysfunctional, the patient will have respiratory distress. If only one vocal cord is injured, the patient will have hoarseness and may be at risk for aspiration, but will still be able to breathe. So let's segue into discussion of pheochromocytoma. Let's start with a question. A 36-year-old female has a known pheochromocytoma. She has just started taking phenoxybenzamine. Which of the following will this drug impact? A. Hypertension. B. Hyperglycemia. C. Cause a volume deficit. D. Answers A and B. Or E. Answers A, B, and C. So it will impact this phenoxybenzamine will impact all of these conditions: hypertension, the hyperglycemia, and the volume deficit. So answer E is correct because phenoxybenzamine is an alpha adrenergic blocker and improves all of the conditions associated and seen with pheochromocytomas. So what is a pheochromocytoma? It's a catecholamine secreting tumor. It is the cause of about 0.1% of patients with hypertension. So it's a very unusual cause of hypertension, as you can see. However, it's a very serious cause of hypertension. And these tumors result in hypertension that is poorly controlled or impossible to control, typically with normal kinds of drug dosages. Pheos may progress to heart failure and dysrhythmias. They rarely present intraoperatively with hypertension tachycardia, but it always should be within one's differential of intraoperative severe hypertension and tachycardia that is difficult to treat. It may also result in death if unrecognized and untreated. It may be associated with other syndromes, multiple endocrine neoplasia type 2A, which is also known as Sippel syndrome, is the presence of medullary thyroid carcinoma, pheochromocytoma, and hyperparathyroidism. MEN2B is the presence of medullary thyroid carcinoma, neuromas, and pheochromocytoma. And von Hippel-Lindau disease is a non-MEN, which is 25% of patients are associated with pheochromocytoma, one of the more common associated diseases. So pheochromocytoma is classically described as episodic hypertension, but with orthostatic hypotension. Pheochromocytomas can be sort of viewed as the rule of 10, meaning that about 10% of the time these tumors are malignant, about 10% of the time they are bilateral, about 10% of the time they have a familial association, and about 10% of the time they occur outside of the adrenal glands. Classic symptoms of a pheochromocytoma include sweating, headaches, particularly with the elevation of blood pressures, palpitations, pallor, tremor, cold extremities, diaphoresis, hypertension, difficult to treat hypertension, marked hypertension, and tachycardia. They can be precipitated by straining, constipation, exercise, abdominal trauma, and anesthesia. Preoperative preparation of patients with a pheochromocytoma consists of alpha blockade. Typically phentolamine or phenoxybenzamine have been used in the past. Beta blockers can be utilized and frequently are utilized, but only after alpha blockade to avoid the unopposed vasoconstriction. So how does one diagnose a pheochromocytoma? Well, the classic diagnosis consists of 24-hour urinary collections for metanephrines or norepinephrines, and this is the best diagnostic test. It has a very high specificity, along the order of about 99%. Plasma metanephrines can be used if it's impossible to get a 24-hour urine collection. The specificity does drop to about 88% with the plasma metanephrines compared to urinary metanephrines. A CT scan looking for an adrenal mass is utilized only if biochemical tests are positive, because there's a high likelihood of finding incidentalomas or benign non-active adrenal masses otherwise. A CT scan has about a 96% sensitivity to discover an adrenal mass. There's a low specificity for pheochromocytomas without the elevated metanephrine levels. Another diagnostic tool that can be used, particularly for those patients who do not appear to have adrenal masses, are MIG scans, or MIBG, which is a meta-iodobenzyl guanidine scan. The sensitivity is about 80%, specificity is 100% for pheochromocytoma. Other tests include plasma catecholamines, urine vanillin mandelic acid, or VMA levels. So what about anesthesia for a patient with a pheochromocytoma? Well, the blood pressure should be adequately controlled preoperatively. These patients should have adequate alpha blockade and beta blockade before undergoing anything except truly emergency life-saving surgeries. One should make sure they have adequate access and invasive hemodynamic monitoring. Arterial lines are pretty much standard of care. Central access can be used, but may not be necessary, particularly in patients who do not have heart failure. One wants to ensure adequate anxiolysis and depth of anesthesia before proceeding with the anesthetic. The ligation of the tumor's venous supply will lead to hypotension, so one should be prepared at that point to provide fluids and vasopressors. Most commonly used is phenylephrine, but may require more potent vasopressors such as vasopressin or norepinephrine even. Laparoscopic surgery is becoming the standard of care in resecting these tumors, and remember that the pneumoperitoneum, or the positioning for the surgery itself, may cause release of catecholamines, so be prepared to treat with vasodilators. Commonly nitroprusside is used. One should avoid sympathomimetics or anything that can indirectly cause release of catecholamines. This includes ephedrine and ketamine. One should also avoid medications that release histamine, and which includes morphine and atracurium or cisatracurium. One should be prepared to treat acute intraoperative hypertension with typically sodium nitroprusside, phentolamine, or beta blockers such as labetalol or esmolol, and be prepared to treat cardiac dysrhythmias. Again, beta blockers such as esmolol are very useful, but only if the patient has been adequately prepared with alpha blockers ahead of time. Thank you very much for your time.